Welcome to Law and Justice. I'm Jane Mulcahy, and today I'm so excited to be joined by Dr. Wendy Ellis from America. You're in Washington, D.C., isn't it, Wendy?
That's correct. Yes, I am.
Well, thank you for joining me on this special Law and Justice series on how to talk policy and influence people. And so before we get into adverse childhood experiences and public health and all of that kind of thing, maybe you can tell me about yourself, Wendy. It's okay if I call you that, is it? Or do you prefer Dr. Ellis?
Please, yes.
Okay, thank you.
Wendy
Thanks.
is fine.
Okay, so just a little bit about yourself, Wendy, would be super to start.
Yes, so I run the Center for Community Resilience at the George Washington University here in Washington, D.C. It is work that's based on my research and experience over the last 20 years of really trying to put depth and meaning to that word resilience. That goes beyond thinking about individuals, but really the context of that community in which we all thrive or we don't thrive in, depending upon what are the supports and the buffers that are there to help us bounce back. And so, my work is very much informed by my own personal experience, but also my experience prior to being in public health. I was actually a television news producer.
And oh, wow. Okay.
That's a natural transition, right?
Yeah.
To go from TV news to public health research. But actually it is. When we think about, particularly from a public health perspective, public health is rooted in social justice.
Mm-hmm.
I got into TV news because as an African-American woman, at the time that I got into news, there were not very many of us who were behind the scenes making editorial decisions about the stories that we covered and how those stories were covered. And I thought that perspective was something that was much more important than me being in front of a camera reading out loud.
I get you.
I learned in elementary school. I didn't need to do that as a profession. Yeah. So that experience of being behind the camera really required me to learn a lot more about the communities of which I lived in, and the politics, the policies, some of the history that drives some of the outcomes that we saw in community. So I tell people a lot of times, as a journalist, you have a license to be nosy.
Yeah.
You can ask questions that, perhaps other people wouldn't be able to ask or would find it quite rude to ask that question, right? And yet that's your job. And so I had access to individuals who could answer some of those probing questions. And what is that? That's data gathering. Mm-hmm. And then to put all of that data together and write a story, well, that's analysis.
Okay.
And then that story, you want it to further a cause, which is very much what we do in the public health realm. Is we gather our data, our primary data, we synthesize it, we do the analysis, and then we put it out there for the field to embrace, to test, to what have you. So for me, going from that realm of, television journalism to public health research, I hope now why it's obvious now that it seemed like quite very much a natural. And I had been interested in childhood adversity from my own personal experience of a child who, I myself have an ACEs score of 8.
Okay.
And my understanding of resilience from Ann Maston's work around what were some of those individual supports that are necessary to help children and families bounce back, I began to make some correlations, in my own upbringing of how, despite having such a high ACEs score, I was able to graduate from high school, to have a robust career, to move forward, and not only one career, but 2 careers.
Yeah, very successful ones, yeah.
Right, and so, and that, coupled with the social determinant literature as I got into public health research, really did help to inform, how will we define, for me anyway, the basis of my research was like, how will we define what community resilience looks like, and how do we go from just treating individuals to really thinking about that community context and getting to the root cause of adversity and trauma.
Fascinating. I had no idea about the media angle, but it does in a way make a lot of sense, you know?
Yeah.
And also bringing the kind of statistical correlations then to personal narratives and seeing what are the resilience factors and buffers, like you say, in someone's life. So how I discovered you, Wendy, was I think on Twitter. I think it was a pair of aces.
Nothing good happens on Twitter.
Lots of good things have happened through Twitter. I found all manner of wonderful people. But I think it was the pair of aces graphic that I saw first.
Yeah.
And then I went and found the article about building community resilience. But can you maybe, before we talk about that model, can you maybe tell me, as someone who's delved a lot into public health now, what is the importance of the Adverse Childhood Experiences study from 1998 from your point of view?
Yeah, I think from my point of view is that it really gives us an opportunity to understand, at least from from here in the US, to understand the commonalities of these chronic diseases that we see that are the leading causes of death in the United States. So when you look at obesity, when you look at substance abuse, when you think about heart disease and even suicidality and mental health and behavioral health issues, one of the things that not just the ACEs study, but the subsequent studies at looking at the association of ACEs to all of those things really provided a platform to understand and I think reinforce why going down any one specific silo, say, we threw $30 billion after solving obesity, and we barely moved an inch on that one, quite literally, and measuring inches on individuals. And so if you're not really paying attention to these cross-cutting factors, and it does go through, like ACEs provide us an opportunity to look at how these events early in life can impact a number of different outcomes across the life course. And there's so much science to back that up that it has opened up this window, this opportunity, this potential for what if we were to really look holistically, not at just what is wrong with people from a clinical standpoint, but really understanding what's happened to people and take into context what were the factors that were associated with that. It's one thing to, and I think that, the literature kind of bears this out with regard to looking at individuals who, like myself, may have an extremely high ACEs score, yet that score is not deterministic. It might be predictive of some special supports and buffers that I might need. And I had those. I had a strong faith-based community. I had 2 sets of grandparents. I had excellent schools to go to and teachers that were supported so that they could support a child that they saw both had some issues, emotional issues, but also had potential. Like I wasn't defined merely by just what had happened to me. There were other things that there was a reason to invest in this kid. And so I think that has been the value, or it still has the potential value, because I don't think we fully have realized the value of the ACEs studies and subsequent studies, not just the original ACEs studies, but the subsequent studies to show those connections across the life course. And, I do believe that 30 years from now, we'll be looking back on it like, yeah, it wasn't that common sense to me. That was a controversial idea at one point. But I think we're at a tipping point now that there is an understanding. It is the question, and this is where the BCR work came in, is okay, we get it that all these things are connected, but what are we supposed to do about that? How do we go about doing something about that?
And one of the major criticisms, I suppose, from people who are a bit afraid of that deterministic aspect potentially, or the fact that I am not defined by my adversity, I am more than it. I am also, I've great resilience, or I don't like the fact that you're saying I have an ACE score of 7 and I should be more at risk of addictions and mental health and all sorts of things. But one of the main criticisms is the maybe the failure to attend to the nature and the timing and the intensity of the adversity. So in early infancy, we're more malleable and, you know, more perhaps harmed by certain factors. And then the absence of structural issues like poverty and the race dimension and also cultural trauma. Are these criticisms valid, do you think, Wendy?
I think that they ring true with what we know about human development and the development of any disease. You know, you can have siblings that grow up in the same household that have the same genetic predisposition, say, for heart disease. One sibling decides to participate in athletics and, you know, has a different diet, you know, just has a different preference for foods than, say, the other sibling who just is not interested in athletics at all, is very sedentary. And so you have one sibling who does have an early onset of, say, diabetes or heart disease that was the genetic factor wasn't deterministic. It was there in both of them, but it was the chain of events, the decisions that were made, and how those decisions open up different opportunities for the supports and buffers, the protective factors that say, you know, if you had the one sibling that said, yes, I have the same genetic risk that my brother has, but I chose to exercise and really watch my diet as a kid and as an adult. And so I don't have the same expression of that genetic risk as my sibling. I think that we will see ACEs will play out similarly that way. And one of the things that I think is important too is that we weigh so much, well, there has been a push to put so much weight on the score itself.
Right.
And the literature does bear out that the higher your score, there is an allostatic load there that I recognize is fully valid, but that does not necessarily account for the resilience factors. We can't just add up this is a two-sided equation. And so you can't just add up, you know, ACEs scores and adversity exposures without thinking about those things that might offset the effect of those ACEs. The other piece of this is, you know, like with myself, my 8 ACEs are across 8 different categories, but they're also across different points of my development.
Right.
If there was a very concentrated point in my development, like from 0 to 4, where I racked up probably about 5 of my ACEs just in that short window of time. But in that short window of time, I also almost had immediately the support of my grandparents and a very small group, very small social circle that just came in and was just trying their best to offset that, right? Yeah. So, I mean, I do this because that's really what I feel like when I think about that period of time. It's like, you know, there was the bubble wrap that was put around me, and this acknowledgement that, wow, we really need to do something special for this kid. And then the other ACEs happened at other periods of my development. And by the time like the last 2 hit, I had already kind of gained had a sense of like what it was going to take to protect me, who I needed to go to, and what were going to be some of those positive adaptations that I needed to make to protect myself. And so, you know, that's not to say that, you know, everybody with an ACEs score has had that kind of support and buffer, but I think that is, you know, we already have in the literature, like Ann Maston's work shows us, you know, what are those protective factors, but what Ann Maston's work should be expanded to, and what I'm hoping that I'm contributing to, is this understanding of, well, what do we need to put in place at the macro level so that families and individuals can provide that buffer for individuals. And one would think that if you are doing this at the macro level, you're actually preventing that adversity from occurring in the first place. So I understand the criticisms, but I do also understand that we still need to be curious about all those factors that you talk about the effect of timing, chronicity. You know, it might be one ACE, meaning like one category of ACEs that happen over multiple times that, you know, could have the same effect as having 8 different ACEs.
Yes.
Or, you know, we know that you can have one ACE happen in a person's life, and that has the same effect as 8 different ones over, you know, a course of time. But I do think that the ACEs science has to be informed by the resilience science if we're going to move forward in using this information, this body of work, in a productive way.
Yeah, it's like, what do we do with it now that we know these things happen and are very common, are prevalent across all classes, all races, all education levels? Then what do we do now? So tell me a little bit about the pair of ACEs. And it's an amazing graphic, but what does it tell us? Basically?
It's so simple. It really is simple. I mean, you know, one of the things, and this does, you know, I think is a reflection of my work as a communications person, as a journalist, is that, you know, you have to be able, if you expect people to be able to take some set of actions, whether that's advocacy, whether that's a change in their own behavior, fundamentally, they have to be able to understand it. And so, you know, when you think about the ACEs science, you know, we use these big words like chronicity and, you know, allostatic load and what's happening with the APH axis, and all of those things are really important, but they fail to reach the people who either, number one, need to heal themselves, need to be able to see themselves in the work, and need to understand, like, what is the problem that we're trying to solve here, folks? So when I first wrote when we first started the Building Community Resilience Collaboratives, one of the first requests from all of our teams were, how are we going to enter into a conversation around ACEs and people feel comfortable? How do we normalize that? Because invariably we know that if you're in a room full of 20 people, that according to the statistics, probably half of them have at least one ACE, or 2 ACEs at that point. And so how are you going to talk about this subject that no one really wants to talk about, and make them feel comfortable that we're not talking about, yes, we might be talking about you, but we're not asking you to reveal your own past. But, you know, how will we discuss this in a way that you understand the problem and that you can see yourself in the work? You can actually begin to see a solution. So I wrestled, actually that tree was put together in one afternoon.
Yeah, who said it take years? Yeah.
No, it was, and I've told this story a couple of times, but I had to do a presentation the following day to a group of, it was more of an immigrant health group that had no exposure to ACEs. They would not know what adverse childhood experiences were about, yet this was at the heart of what was really tearing at this population, this immigrant population here in Washington, D.C. And so I was like, oh, I can't go in there with the brain scans. I can't go in there with the, you know, all of the ACEs statistics, because I'm going to lose them. And then they'll miss this opportunity of something that could be really constructive and impactful for this community. So I just started thinking about root causes, and it's like, okay, yeah, they got to think about the context. And the tree came about that way. I was like, okay, so average childhood experiences, that's what we can see, and we can wrap our heads around that context. But what we don't immediately see is the context in which it's occurring, that oftentimes exacerbates, if not is a direct cause of the adverse childhood experience itself. And we, you know, I put the 10 ACEs across the leaves and the branches. And then I started thinking about, you know, we don't want to be exhaustive in the roots. We just want to give them enough for them to begin to think about root causes. And And that's literally, I was, my advisor was at a National Academy of Sciences meeting, so he wasn't even in the building that day.
Right.
Um, and I was like, hey, this is what I'm kicking. So he was on his phone looking at what I was sending back and forth, and he was like, oh, you know, I had something in yellow. He's like, no, don't do it in yellow, put the font in red. And then I had, we were changing fonts, and then we were changing like order or what have you. Yeah, so I spent 6 hours, I think, that day just working on that tree, and we were going back and forth, and I dropped it into my deck. Didn't think twice about it. I was like, oh, we'll have to go back and clean that up, that's for sure, but it'll work for tomorrow's presentation. And little did I know, I mean, it really took
Broke
off.
the internet almost, you know. Well, in ACEs circles anyway, I'd say
Yeah.
one of the single most shared.
Yeah.
It's really evocative, and it actually counters a lot of the criticisms of the original study, in the sense that it situates the individual and the families within the community context.
Right.
And the stuff about housing and community violence and lack of employment and social mobility and all of those kind of things. So moving on then to the Building Community Resilience project itself, why did you set that up, and what does it aim to do, Wendy?
So again, this goes back to being a journalist. So what led me to leave TV news was a story of child abuse in Seattle when I was living there. It was a case, this little girl named Loria Grace, who died at the hands of her mother, who was in a drug diversion court program. So if she agreed to go through the mother agreed to go through treatment, as opposed to being adjudicated, so as opposed to going to prison, then Loria and her mother could stay together. Loria would go to a therapeutic daycare program during the day, so that she could receive, obviously the therapy that she needed after, dealing with her mother's drug addiction. She was about 3 years old. So unfortunately, the mother relapsed, and her relapse was not a surprise to the caregivers at Child Haven, the facility that was helping Loria, because she was becoming dysregulated. She was showing signs of abuse, and Child Haven did everything that they were supposed to do. They reported to child welfare, they reported to the probation officer that they had their suspicions, and every agency that should have been there to protect both Loria as well as her mother failed to do any of the follow-up. And so when Loria was discovered, I was still working in news, and I was outraged. I was outraged, number one, that all of our public systems have failed. But I was also outraged by the fact that my newsroom wanted me to just do the story, okay, go and do your interviews or what have you, and then we got to move on to the next story. And I just thought, see, that's the problem. We have so much potential to create a platform for conversation. This microphone that I hold, this camera that I stand, behind, actually has the power to get people to talk and to enter into a public dialogue that is absolutely necessary if we are truly here for protecting our children and guardians of our community. And the fact that, it was more important to go and do a helicopter live shot from a burning house, like who hasn't seen that on a TV newscast before? I just thought, this isn't solving the problem. And so that's when I left TV news, and I ended up going to work for Child Haven for about 6 years as on their executive board, and really began to understand that it was this disconnect. Like what happened to Loria was happening to thousands of kids here in the United States and across the globe, is that you have public agencies that have little slices of all of our lives, whether that's healthcare and the delivery of our healthcare, whether that's social services and, say, the delivery of supports for behavioral health is disconnected from mental health, which is disconnected from education. And if you have a parent that perhaps has been justice involved, that's even more disconnected. Parole services are going to be even more disconnected from all of these things, as if, we can slice and dice a person and none of those pieces are connected. So I had become very oriented to the ACEs science. Anna Folletti's work had just come out. This was 99, 2000. So it was like, it was fresh off the presses.
Wow.
It was very resonant, with our agency. And I had an opportunity to meet Folletti, who had come to do one of our annual luncheons, and just, I went back into journalist mode and just asked him every question I could potentially ask. And it really opened up my eyes to understanding that the issue wasn't that people could not grasp the issue or grasp, the call, the need for action. It was, well, what am I supposed to do about this?
Yes, it's too big for me.
It's too big. It's too big. And so, I started studying the Medicaid system of care in Washington State, and that was my thesis, my master's thesis at University of Washington. And one of the things that I found in that very first study was, like, part of the reason why we had kids that were just lingering in community was that we had these, policies that restricted a child's access to some of the more fundamental and preventive behavioral health care until they were already, like, at crisis.
Mm-hmm.
So, again, that's a very expensive model of care. If we're waiting until they, need medication and they need to be potentially in a residential facility, and it's also cruel.
Totally.
Let our children linger like that, when there's something that, if we could catch it earlier, we could prevent a whole host of outcomes and actually lift these children up. So when I came to Washington, D.C., I started, really trying to understand, well, what would it take? Because at that point, the ACEs stage, this was in 2011. So at that point, I felt like ACEs should be a common understanding, particularly with pediatricians. So I did like 2 years of qualitative interviews with pediatricians, just asking the fundamental question. Well, number one, do you know about the science of ACEs? And if they did, then, question two was, so what are you doing about it?
Nice.
I mean, it wasn't putting anyone on play. I honestly wanted to, so what are you doing about it? And it was really interesting for those who were steeped in it. It's like, I don't know what to do.
Yes.
Or, I've thought about asking questions about it, but it is like opening up a Pandora's box. Yeah. Or when you start talking about some of these other issues, whether it's a parent's substance abuse disorder, or it's about homelessness or something else that is creating these stressors, what am I supposed to do about that? I'm a pediatrician. I have 15 minutes. I'm doing a well check. So literally I walked out of there like, really? Is this the issue? It's that simple? We just don't know what to do? Oh, I can figure out I can write a process for that. So that was where literally the BCR process was born, out of this simple, understanding that we can have this complex science and we can have all the evidence that we want, but if we can't fundamentally help people see themselves as a part of the solution, then we'll never get to solving the problem. And so it was, based on these things that, at first glance looks like this is public health 101. Create a shared understanding.
Right.
Of the ACEs narrative. What is the narrative of your community? Do a systematic assessment of what is the, what's your system's capability? What are your provider capabilities? Where you see those gaps, then that begins to help you understand who are those cross-sector partners that should be at the table. How do we knit this together so that we truly are, not only responding in times of crisis, but providing this net so that our children and our families can bounce forward. And then the most important piece of this, which is public health 101, but I think is the hardest part for us to do, is that authentic community engagement.
Okay.
It's important both to establish the shared understanding of the adversity, because we can't just look at it from the perspective of systems data. You know, if I talk to physicians and they're going to tell me about their utilization data, they're going to come up with one list of outcomes that are, these are absolutely the number one priorities for our community. If I talk to educators, they're going to look at their outcomes data and say, these are absolutely the things that we should be addressing. If I talk to criminal justice, they're going to say, well, these are all the reasons why I'm arresting kids. These are the things that we should address. And it's like, yes, you all are right, but you're only looking at it from your perspective of that silo. And guess what? Those outcomes are all interrelated. And if you just go down one silo, you're not going to solve the problem. So it was, and you don't understand the real lived experience that feeds into those outcomes. So you have to have the community voice there from the very beginning to help inform what are those outcomes that we see, what is that lived experience. So that, you know, I look back on it now, and I was actually first surprised that my mentor was like, you're onto something, keep going. I was like, really? It seems too simple. He goes, no, not by any means. What you're talking about is big. And I said, oh, okay, sure.
It's that big picture approach, and kind of, I only discovered the word consilience during my own research and PhD, and how we need to bring facts from different disciplines together and join them all up. And I do like that idea, because like you, everything is interconnected. You know, we can't parse it out, or if we do no one any favors. So you've actually implemented, though, this model, haven't you? And in six places, 6 sites?
So it's in 10 places now, because we have the second project that we started with Resilience Catalyst and Public Health. So that's with local health departments using the BCR process. So yes, it's been implemented officially in our networks in 10 communities, but there are a number of other networks and associations who, you know, they've had me come in and do one-day workshops, and then they're implementing it without our facilitation. So
Well, it's so exciting, because we spend so much money on all the wrong things, or, you know, on just picking up the pieces, you know, and a lot of it in terms of the relational buffers that help children and adults heal from trauma. Also, we need relationships in order to actually keep that healing ongoing or prevent it. You know, it is the talking to people in criminal justice or child protection, talking to doctors, and having shared goals, I guess, and shared outcomes for the community as a whole. I've heard you speak quite a lot about inequity on videos, and that's a big part, I suppose, of the concept of adverse community environments as well. Not all communities are the same. They're not all equally privileged. They don't all have good health or education outcomes. What has to happen? I mean, I suppose we're in COVID-19, so just to draw on what I've heard about what's going on in America right now, and again, the very compartmentalized or fragmented approaches to dealing with the COVID response, and then the fact that the death toll has been quite different for different communities. So for African Americans and for Native Americans, the risks are higher. Is that, do you think, partly due to inequity and the fact or maybe to do
absolutely. I mean, absolutely. It confirms this understanding that, you know, if you are living with chronic stress and chronic disease, that you are going to be much more susceptible to something as virulent as COVID-19. What is most important, I think, is to understand why you see these patterns of poverty and chronic disease coupled together. And that is the work that really brings in the policy aspect of this, that we have to understand what's and why I, you know, put in the roots of that tree all of those things that I'm talking about are not individually driven
Not at all.
outcomes. Those are outcomes at the systems level that are driven by policy. Those policies were deliberately made for the outcomes that we see. So, it was important to me that from an ACEs perspective, we did not use this science to begin to think about how do we reprogram people.
Sure.
Yes, treating people is absolutely important. There's nothing that I would argue against that. But that is a piece of the work that needs to be done here. We can't patch people up and send them back out into these broken environments that were meant to do exactly what you see. And so, when you look here in the United States, one of the things that, and I think, for any a country, this can apply across the globe, particularly countries that were former colonies, that it was deliberate that there would be this power and privilege hierarchy, and the policies were written to continue that generation after generation. And so when you're in the United States and you see that there's a racial wealth gap, well, that's by design. When you look at our housing policies, which is the number one way that we pass intergenerational wealth in the United States, is through the deeding of property from one generation to the other. And so when you have federal policy that restricted the ability for people of color to even be able to get these federally backed mortgages, that was 70 years ago, and they actually redlined, they drew lines around certain parts of cities that if they were predominantly of color, they would not have access to the capital to finance those homes. So when you lay the red line map on top of where we see COVID deaths, the concentration of COVID deaths, which also happens to correlate with where we have concentrated in intergenerational poverty and the chronic diseases, you see, because the social determinant literature already shows how all of those things are outcomes or associated with chronic disease and these negative outcomes. So of course, you add COVID-19 to the mix, it's only going to hurt that community more than some others because they're the most vulnerable. The other part of what you're seeing too is not only the historical impact, but also how our investment or disinvestment in social policy has crippled certain parts of our community in light of COVID-19. But we're always there in plain sight anyway. So you think about when the data first started to be distributed here in DC about where the positive cases were, the predominance of positive COVID-19 cases were, they were actually in areas of the city that were a little bit more affluent.
Oh.
Not the areas of concentrated poverty. And I remember looking at that first map and I went, you're not looking at a map. Just understand what these data show. These data do not represent who has COVID-19. They represent who has access to testing.
Yeah, there you go. There's the rub.
There's the rub. And, because they were in wards 4 and ward 6 here in Washington, D.C. Ward 6 is right around Capitol Hill area, so a lot of staffers, for congressional staffers, White House staff, agency staffers, people with health insurance. If you had a little bit of a dry cough, you could go to your doctor and get an order written so you could go get your testing. Ward 4, a lot more elderly, affluent families. So, of course, again, access to primary care. So if you think that you might have been exposed to COVID, you could go and you could get an order, you could get tested early. So Ward 7 and Ward 8, they, which is predominantly African-American, there's only one hospital in that ward for 50,000 people in those two wards. And there is a lack of primary care. And it's a huge healthcare desert, a huge food desert. And so, no, there's not going to be the same access to testing.
No.
And that's all that those data were first showing us, is who's tested positive, not necessarily who was infected.
Oh, that's so
And
interesting. Yeah, even about the
yeah,
reliability just of data and the questions that you ask.
well,
Were
you have to, I mean, and that is, you know, again, this goes back to, I think, my training as a journalist is not just to look at what data is in front of you, but actually ask yourself, what is this not telling me? What is this not showing? What's missing from this story here? And that was the first thing that just like screamed out at me. It's like, so you're just showing me testing data. You're not really showing me the prevalence of the disease or the virus in the community. And so sure enough, it was less than 2 weeks when you began to see the disproportionate numbers of death. And, you know, those are individuals that are showing up in EDs, emergency departments, and or they were dying in community. And I think that's another part of this story that unfortunately will not be told until we do begin to resume to some sort of normalcy, is how many in-community deaths that we have, and the likelihood that those will be disproportionate to communities of color as well as immigrant communities, those that have the least access or because of their immigrant status may not necessarily seek health care.
Because they're afraid of the consequences.
Afraid of the consequences, yeah.
Yeah.
Yeah, yeah, absolutely.
One other aspect, I guess, though, of the inequity in the States is the lack of the proper social safety net, you know, and paid unemployment leave or monies to people. My own husband's American, so I admire many things about America, but it's one of the things I don't get, this lack of kind of a welfare safety net for people when they need it, because then you have to go to work when you're sick.
Right.
Because food needs to be put on the table for kids.
So the lack of sick days, paid sick days, the lack of, you know, even thinking about childcare. So who's taking care of your children when you have to go to work? All of those things. You know, one of the things that is not getting enough coverage in the United States, and I'm trying my best, the one-woman band here, but one of the things that we have to consider, you know, what's the rush to reopen? And really looking at, you know, in the United States, everything always comes back to the money. So when I'm training folks on how to do the policy and advocacy work for this, you know, in support of ACEs, it's like always follow the money, because the money will tell you where the priorities are, where these budgets, city budgets, state budgets, federal budgets, where we put our money is what we see value in. And so if you begin to investigate some of the state budgets that across the United States, I mean, everyone has a deficit right now, a huge deficit because of COVID. Some states more than others, but Georgia, for example, Governor Brian Kemp, who was the first to rush to reopening Georgia, has a particularly looming budget crisis on his hands.
Okay.
And what's one of the easiest ways to take a lot of that debt off of your ledger is to shrink the roles of individuals who are on your unemployment rolls. And if you have a stay-at-home order in place, then people can't look for jobs and they can't apply for jobs, so they have to be on unemployment. But if you lift that stay-at-home order, you can kick all those people off of unemployment, because they can no longer say, well, I can't even look for work right now, because they can look for work. And so that's really, you know, it sounds very pessimistic, but we know that that's a motivating factor for a lot of these governors, is to look at, you know, it's a debt that I can't carry. So cynically, I'll just, if I open up the economy in that regard, then at least I'm not obligated to pay these individuals.
Pretty grim. Pretty grim, but yeah.
That's the American story.
Yeah, sadly. One question on screening, because I've taken a lot of your time, Wendy, but screening is a somewhat controversial issue in all of this in relation to adverse childhood experiences and trauma. Nadine Burke-Harris, the amazing Surgeon General of California, is quite in favor of it, and Center for Youth Wellness in San Francisco do it. the CDC in late 2019 also kind of came out and said enhanced primary care screening and supports for families and communities was necessary. But I recently read a piece by Robert Anda, who was one of the original ACEs gurus, and some of his colleagues wrote a paper saying that the ACE score is kind of a blunt instrument, that it was never designed to screen individuals. It's a piece of research, you know, a research tool. And he made the point that you did, that one ACE for a person can have as big an impact as 8. But as a public health person yourself, what is your view on this, Wendy? Is there merit in asking people about ACEs, or you know, trying to get a sense of their exposures, you know, not just to the original 10, but also the wider ones, you know, the racial trauma, the historical trauma, the housing, all of that? Or is it dangerous?
I think that there's, you know, it's fair to have a conversation to understand what level of adversity is a person carrying, whether it's their history, whether it's current, that may feed into the clinical, you know, aspect that you are treating. I think a conversation is appropriate. I think to apply the ACEs instrument as some sort of diagnostic tool is completely inappropriate. I'm with Anda on the fact that that's not what it was intended to do. I do understand, you know, I have high regard and great respect for Dr. Harris, but one of the issues is that, you know, she had a very ideal clinical practice where you could do what would be absolutely necessary and appropriate in responding to an ACEs score. That is not something that California Medi-Cal, what Medi-Cal is going to be able to provide to all of these, you know, providers across the state of California. These smaller providers are not going to be able to have that sort of wraparound response within their clinical environment. And so, and, you know, the likelihood of, even with training, of every provider being able to do it in a manner that is not like clubbing, you know, your patient, it's not worth the risk when we think about, you know, the potential to re-traumatize individuals. I do like what some of our clinical partners are doing here in the United States, one in particular, Children's National, where they looked at not just their utilization data with regard to outcomes, pediatric outcomes, but also thinking about what do we know that our families are struggling with in community? And what might be a place where if we ask just one question and we could solve that one problem for our patient population, but perhaps by addressing that might open up the door where they would be more comfortable to talk about perhaps their ACEs history or some of the other stressors that are occurring in that household. And so they started asking a question around food insecurity.
Wow.
And this was about 3 years ago. And we know food insecurity does not exist by itself. Typically, families that are experiencing food insecurity probably also have household instability. Certainly, there's economic constraints that are there. And those things can come under one roof to create an even greater stressor as far as a parent's ability to be able to do positive parenting, which then could be associated with an ACE, and may also be their ability to handle that may be influenced by their own adverse childhood experiences, their ability to handle chronic stress. So by doing so, they were able to better understand the multiple adversities that are happening within households, address, you know, by doing so, you know, they made sure that they had the ability to address if food insecurity was being uncovered, then there was a way to connect families to resources. But by doing so, you actually create this trust with families, right? Mm-hmm. And that opens up an opportunity for dialogue where these other ACEs might, you know, become apparent or be shared. And, you know, and that has also informed like this holistic group of services that they've done, you know, transcendental meditation with parents, thinking about mindfulness, but also thinking about those things that need to be addressed so that they have food on the table, so that they're reducing the stressors in the household, and not just being told, you need to change you. There's something wrong with you that we need to fix. So, so I think that type of approach is not the blunt instrument.
Mm-hmm.
Rather, it is coming in with that warm hug that many of our families need. Mm-hmm. I am very concerned, and it's interesting you bring up the fact about CDC at one point, indicated this interest in having some level of screening, but we are partnered with CDC, excuse me, on an initiative to use the BCR process with local health departments, excuse me, to use the BCR process to get at this intersection between adverse childhood experiences, suicide, and opioid misuse, because the three are very much intertwined. And so how do you begin to unpack those things? And we're not using a scoring index, but really entering in community conversations that get down to what is the experience of adverse childhood experiences as it relates to your community? What is the experience of suicidality in your community? What is the experience of opioid and substance abuse? And help us understand the root causes of those things. I think we have to go beyond just trying to find these purely clinical approaches without considering the context and all of the different partners that have to be at the table.
Yeah, that makes a lot of sense. One thing that I find very interesting about it, and I'm not a clinician, so I don't know, but a lot of these things don't come out if you don't ask,
Mm-hmm.
People will go there. Some people go to their grave without ever divulging anything to anyone, and it's a huge weight to bear.
Mm-hmm.
And lots of people I've met who might have had addiction histories and offending behavior or all manner of problems kind of go, wow, when they get the information. So might there be a thing where doctors or someone tries to make this information more publicly available? I know you're doing it in the work that you do, but might there be scope for some sort of public information campaign? Or do you think that the States or any country really, I mean, Scotland have done a video on adverse childhood experiences and Wales have, but do you think there would be benefit to bringing just the information to people and kind of saying these responses are normal? Opioid addiction is actually normal if you've had it's not a surprising thing.
Right. And I think you're right. You're hitting the nail right on the head in the sense of we do have to normalize the conversation around these issues. If you think about, and we've got a great history of doing this in public health, normalizing the idea that if you go back 50 years ago, the idea that you would walk into a restaurant or a bar and no one's smoking and that smoking is illegal, like that would have violated so many social norms at the time. And now we all look at it's the opposite. If someone's smoking in a restaurant, it's like, what in the world? Did he not get the memo, or did she not get the memo? But that was a process of actually socializing this concept, this understanding of the dangers of smoking, and understanding that it's not about bad people, but it was really about an addiction. And how do we begin to treat that addiction so that there are people who smoke, but they're not smokers. There's a difference there, right? There are people with addiction disorders, but they're not addicts. And so really, how do we, begin to normalize the conversation around adverse childhood experiences? In my work, I call it as a national public health issue, that it is happening to all of us. The likelihood is that you have one. And for some of us, it has not stunted our growth. We thrive in despite of. There are others that haven't, and understanding what was missing for them is key to healing the nation, not just that person. So I think, we have to find a way to normalize a conversation around adverse childhood experiences, create this conversation that individuals can see themselves as both a survivor or a protector, or you can be both, in the same skin. I think that's what's more important than actually going down a list and asking people, did you suffer sexual abuse? Did you have a parent that went to jail? I mean, it is really going back to creating trust and relationships in primary care practice, and that's also, I think, part of what needs to be reformed, because everything that we do right now is, what can we do expediently? I got 15 minutes, so which well check am I going to do? And it has to be a checklist, and that's no way. You cannot checklist your way through the adverse childhood experiences.
Mm-hmm. No, it would be dangerous and callous, possibly, or not conducive to trust and relationship.
And I would be remiss to not call out specifically how these data could be misapplied, particularly for children of color.
Right.
In this country, we have a horrible track record of how we categorize and label children of color, and if they have some sort of set point, then they automatically don't go down this path. And I think that would be the biggest tragedy of all, is that because there would be implications for children of color, but even even for white children in this country. If you were to be considered, okay, yeah, she has an ACEs score of 8, but she's going to be okay, and automatically think that children of color, they're going to need this type of behavioral interventions, they're going to need all of these medications and things like that. It's not fair to either one of them, because maybe the 3 Black kids that you saw that day have an incredible social network and they're going to bounce back, but this little girl and her family, they have nothing to buffer them. But because we thought that perhaps her race might be a buffer in itself, a protective factor, without taking into consideration other resilience factors, then we've done a disservice to all of the children.
My very last question, Wendy. Thank you so much. You're fascinating and doing such beautiful work. I watched Becoming on Netflix last night with Michelle Obama, and what an amazing woman, and she was talking about being a young girl and wanting to go to Princeton, and her school guidance counselor was kind of going, no, that's not for you, basically, that you should do something else. But that she always had a great sense of herself and felt visible and, proud and capable because of the loving, supportive family that she had. And she also spoke about her granddad, who was a brilliant man, but restricted in what he could achieve in life. So to go back to the whole thing about policy and influencing policymakers, and given the various skills and tools and brilliant information that you have at your fingertips, I take it you engage with policymakers quite a bit.
I do, yes, I do. Yeah. Yes.
And I guess, again, some people are going to be more receptive to your message than others, because this comes at a cost to do things differently, to try and erode some of the inequity, or to make serious inroads there. If there were 1 or 2 things that you would ask policymakers to do post COVID-19, what would they be?
We have to really begin to address these underlying inequities, particularly when we talk about the access to economic mobility. I mean, that has been front and center in the COVID-19 response. And I think that's globally, where you see individuals who are at the lower economic stratum, these jobs with the least amount of protection. I wrote about this a couple of weeks ago, that those individuals, it's ironic that individuals that are being deemed as essential workers have always been those that have been the least protected. And so essential right now is another word for, using expendable, that they're expendable in our workforce and humanity. And that we really have to invest in all people, but particularly we have to provide more supports for individuals at the lower economic stratum, because it should not be that we have this intergenerational poverty and that it is so set in bedrock here that if you are born into it, that's likely where you will stay. And that, you know, goes against what is the American narrative. But I think it's time that we realize that most of that narrative was fiction,
Mm-hmm.
and we've not lived up to what we have put forth as our values and our principles. And I would hope that this provides the opportunity for us to get to some of those fundamental supports for individuals, for children, and particularly with education, stabilizing households, you know, income supports, as well as household supports. And then also looking at, you know, how are we providing a pathway to economic mobility for people in this country?
Okay. Dr. Wendy Ellis, it has been such a pleasure talking to you. Best of luck with your future endeavors. This was How to Talk Policy and Influence People, a special series of Law and Justice. And I was speaking to Dr. Wendy Ellis about the Building Community Resilience model and adverse community environments. Thank you so much, Wendy.
Thank you, and stay well, please.
Yes, you too.